Okay, so welcome all to the AEG webinar on basics of diagnostic endoscopic ultrasound. This, I think, is the fifth endoscopic ultrasound workshop held in collaboration with the AEG in Sri Lanka. Today we have over, I think now it's close to 100 registrants from 34 different countries world over. The objective of this the workshop is basically to introduce and teach the basics of linear EUS, and also to how to prepare EUS specimens for cytology and histology. We have three presentations from two eminent endoscopists from Singapore and Hong Kong. These the agenda of the program for the day. It's a 2-hour session with 3 lectures. Just a quick introduction of the speakers. I believe Professor Anthony Teoh does not actually need an introduction to a world audience in endoscopic ultrasound, but because today would be all beginners in endoscopic ultrasound, I'll just give a short intro of him. He's a deputy director of endoscopy from an associate professor at the Chinese University of Hong Kong. He's primarily, I believe, a surgeon with a lot of interest in minimally accessed surgeries, but then is also now renowned for his endoscopic skills and primarily for endoscopic ultrasound. He's a frequent name in all the publications related to endoscopic ultrasound and also in world live endoscopy sessions. So that's about Professor Teoh. And our second speaker is Professor Andrew Kwek from Singapore. He was a senior consultant gastroenterologist from the Department of Gastroenterology at Changi General Hospital, and he serves as a program director for Sing Health Gastroenterology and senior residency programs. He's also a clinical teacher at the NUS, and he has trained in advanced endoscopic techniques under Dr. Amit Maidev, and also a lot of interest in advanced ERCP and endoscopic ultrasound, has also published many articles. So without further ado, I would, so probably we'll have the pre-test at the beginning and then over to Anthony for the presentations.
Okay, I will take care of the pre-test. So I'm going to share my screen now. Okay. So I'm not going to do the pre-test. Here are some instructions for you. So the pre-test will last for 5 minutes. And there will be altogether 6 questions. So you can take your time to answer the question accordingly. And we will do the pro-test after the lectures. And the pre-test and pro-test questions will be the same. And the answer will be explained by our faculties after we complete the post-test. So let's get started. Okay, you will see test pop up from your screen now. Please take your time. You have around 5 minutes. You still have around 3 minutes. So 1 minute left for the answer. Please take your time. So I think it's about time. So I will end the pre-test now, and we'll do the post-test after all our lectures, and all the answer will be explained by our faculties, and answer and the statistic of the answer from the participants will also be reviewed. So we can go to next section. So our next section, may I invite Professor Anthony Teoh to present his lecture, Diagnostic Linear EUS.
So thank you for your introduction. Thank you, Nilesh, for your very kind introduction just now as well. I'm going to be talking about the approach to linear examination. I think for any endoscopic procedure, if you really want to learn it, you really need to get your hands dirty. So just by talking, it's probably not a very good way of teaching, but I will try my best and show you some pictures and ideas on how we usually perform the linear examination. So when we perform linear examination, usually we would suggest to adopt a stationed approach. This is usually in the abdomen. So when we examine different parts within the abdominal cavity, we would position the linear scope at several stations, and there are things that we need to identify at each station. So I think for most endoscopists, when they do radio examination, it's usually easier to get a grasp on because the images are easier to interpret. It's often very much like a CT image. So we are more accustomed to these sort of images. But when we do linear examination, a lot of time, when you first started doing it, you will feel very lost. So there are several reasons. First, on linear examination, we are usually looking at the sagittal anatomy, so we are not familiar with this sagittal anatomy. and you look at the images because you're not used to the sagittal anatomy, the images also look very foreign to you. Also in the organs, because sometimes there will be some inconsistent landmarks, so it is also difficult to follow. So very often the questions you will be asking when you are doing a lean EUS is, where am I? What is this? What is that? What is this black thing? Is this what? Is this something else? So this is often the questions that are being asked. But learning linear examination is very important. It is essential because FNA will be the bread and butter for you when you do linear examination. Also, many of the newer linear EUS treatment interventional procedures, these are also based on linear examination. So it is very important, and you need to learn it, and you need to be very good at it as well. And if you have get a good grasp of it, it's actually not that difficult. Okay, so in terms of indications, there are many linear. I think most of the time is to evaluate tumors, and also the need to obtain a biopsy in aiding diagnosis as well as triaging treatment. For therapeutic interventions, there are many as well. So from the most basic ones like injection therapy to fiducial marker placement, pseudocyst, biliary drainage, gallbladder drainage, and the list just goes on and on. Okay, so when you first learn linear EUS, you have to be aware because this is different to radio scanning. So the way that you would be able to scan really depends on the way you move your hands. So most of the time we are actually just moving the scope with one hand, and we are rotating the scope. So if you look at my video camera right now, so the other hand will be just supporting the scope, and you will just rotating the linear scope. So if you look at all the workshops, all the experts doing linear EUS, actually the other hand is often free, and they're just scanning with one hand. And this hand is really just help you do the biopsy of FNA. So with the linear scope, you are also always talking around, looking around in the within the plane. So clockwise and anti-clockwise, counterclockwise rotation is one of the most important a way that we try to see different with the image, the abdomen. So, and also you need to be aware of the orientation. So if the probe of the linear scope is much bigger, the side which is the located where the ultrasound probe is located is the ventral side. So it's looking forward. Okay. So why do we need a sagittal view for the linear scope? Of course, it's because we need to see the needle that is coming out from the channel. So it is in the same plane as the ultrasound probe. And this is essential for visualizing the needle during puncture. The other thing about linear scope, when we examine, because the scope is inserted in the stomach, so unlike a regular CT, which is what I'm showing you right now, very often we are actually seeing the reverse image. So the scope is inside the stomach, we're looking from inside to outside. So very often the image is reversed, and that's why you would feel a bit odd when you're starting the procedure. And when you rotate your scope, you can see on the X-ray, with the scope slightly bent, as you rotate from clockwise to counterclockwise, actually the scope position will change from here to the middle part, needle photo, and then to the rotating outside. So just by using the up-down knob, there will be some major differences in the images because the way you rotate it and in relative to the scope position. And within the EGJ, as you rotate through the the different parts of the liver, you would be scanning from inside towards outside. So the entire image would be in reverse. And that's why you need to be aware of these differences. So essential points. When I teach linear, I always teach my fellows that we should follow station approach. And in each station, you will usually look for landmarks, and very often the most consistent landmarks would be vessels. And once we find the major vessels, then we need to trace the vessel. Ultrasound image is a 2D image, so but the vessels is running in a 3D course. So very often we need to scan around to try to trace the vessel and see how it goes through different planes. That's why we are always moving on EUS. And of course, with linear imaging, you need to remember the images because it will look very foreign to you when you first start to do the procedure. So in terms of the station approach, usually in the abdomen, there are 3 stations. One is in the EGJ, the second one is in the duodenal bulb, and the third one is in the second part of the duodenum. And in terms of landmarks, there are different landmarks at each station. I'll go through each of them with the images to follow. So at the EGJ, so usually we insert the scope all the way to the EGJ first, and then once we are there, I will first look at the liver. I would scan through the liver, left lobe of liver, and look for any liver lesions, as well as the consistent landmarks, including the portal veins, as well as the hepatic veins going into the IVC. And the way to scan through the different parts of the left lobe is again a rotation, a clockwise and counterclockwise rotation. Then the next step would be to try and find the aorta. So most of the time it's posterior to the stomach. So you would do this in a clockwise position. Very often we are holding ourselves on the endoscopy. And in terms of the aorta, we always need to trace the vessels coming out. So the first vessel coming out is the ciliary artery, followed by the SMA. Once we can see the ciliary artery, then we'll trace the ciliary artery to the branching. And then from the celiac branch, we would try to find the common hepatic as well as the splenic artery. So this is another schematic showing you that if the scope is facing posterior, then we will find the aorta and not the celiac off. Once we have the splenic artery and splenic vein, then we actually know that we are actually at the area of the pancreatic body. So pancreas is in front of the splenic artery and vein. I usually trace the splenic artery and vein to the branching at the splenic hilum. And then once we are at the splenic hilum, then we can trace back from the tail of the pancreas all the way to the neck and then the head of the pancreas. So this is the image showing you the scope position. So as we insert the scope, we push it down facing posteriorly, then we will see the aorta. We trace the ciliary artery and the branching of the splenic artery, then we will see the pancreas. The probe is directed posteriorly. So as we rotate the scope, then if we do a clockwise rotation, the scope would scan towards the tail. And we do an anti-clockwise position, then we'll scan towards the head of neck and head of the pancreas. So this is looking from behind. So in the body of the stomach, actually the probe can be used to scan the neck. And sometimes in some thin patients, we can also see the head as well as the uncinate process. The head on the uncinate process is usually can also be seen in the second part of the duodenum. So there are two ways that we can image the head of the pancreas. So again, showing you the splenic artery and vein of the pancreas, all the way to the tail. This is the branching of the splenic vein, meaning we are at the splenic hilum, and this is the tail of the pancreas. Again, pancreas, splenic vein, artery, and also the kidney, left kidney. So also, if we see the kidney, then on the top of the kidney would be the left adrenal. This is often has the appearance of a seagull-shaped appearance. The other thing that you can also try to locate on lean EUS is the celiac ganglion. So why I mention it here now, because the celiac ganglion is usually located between the celiac artery as well as the left adrenal gland. So if you can find the left adrenal gland, and then you also know the position of the celiac artery, then you can try to look for the celiac ganglion, which is usually located anteriorly to the aorta between the celiac artery and the left adrenals. So then we work our way back anti-clockwise, tracing the pancreas body, the splenic vein, and then we usually see the splenic vein coming down, joining the SMV and to the portal vein. For me, I would usually trace the portal vein to the portal hilum, pull back the scope, and then trace the portal vein to the portal hilum, and then see the insertion into the liver. Then I will push back the scope towards the pancreatic neck and try to see the PD entering into the pancreatic head. So you can see this is the SMV. The PD usually moves diagonally downwards and then enters in the pancreatic head. And then sometimes in some thin patients, you will see the CBD and MPD joining together even in the stomach. So this is the portal hilum that I've just mentioned. We trace the portal vein all the way up, and then we will see the entry into the liver. In this patient, the common hepatic duct is also a bit prominent. So you would see this as a non-vascular structure behind the portal vein. You can turn on your Doppler, and then you will see the Doppler, the portal vein being vascular, and the common bile duct or the common hepatic duct being avascular. In the stomach, close to the antrum, usually you would also be able to see the gallbladder. It is usually at the antrum. So if you position your scope at the antrum, if you push a bit along scope position, if you scan around, then you will see the gallbladder. So it's better to see an image, the video, than just talking. So right here, I'm at the EGJ. This is the aorta. This is the first branch celiac artery, second branch SMA. So celiac artery, SMA. If I turn on the Doppler, we can trace the celiac artery here. Celiac artery coming out right there. This is quite tortuous. And then coming into here is the splenic artery. Splenic artery, splenic vein, pancreas, pancreatic tail, and then moving back to the neck. And then right here, I'm tracing the portal vein towards the liver hilum. This is the duct, common hepatic duct. from here, tracing the MPD. This is the MPD. It's a bit prominent, 3 millimeters. It usually goes diagonally downwards here. Right there, towards the head of pancreas. And right there, so I just want to go back several images. All right. So here, this is the sphenic vein. And then right here, it joins into the portal vein. And right here, it's not very clear, but we can sort of trace this portal vein all the way back up to the hilum. Okay. After imaging the within the first station, then I would push my scope into the second station, which is in the duodenal bulb. When we push the scope, you have to realize actually this is a long position, right? This is in contrast to the scope position in D23, which after inserting into the bulb, we would need to reduce the scope like a ERCP procedure. And after reduction, it will become a short position. So in the duodenal bulb, it's a long position. So the bile duct is facing upwards towards the hilum, and then this downwards towards the papilla. So orientation in the D1. So when we insert the scope into the D1, if we counterclockwise a little bit, then this would be towards the medial side of the patient. We would usually see the portal vein, common bile duct, part of the pancreas, and also the neck. So this is what it looks like. Then if we do clockwise turning, we would actually, on the other side, we will see the gallbladder. Okay, so if we do want to do a gallbladder drainage, we would usually do it in the D1. So if you turn your scope clockwise towards the lateral side, this is where you would see the gallbladder. And then when we turn medially, counterclockwise, we will see the bile duct, portal vein, and this is the scope position. As we push in long position further, then we would be able to see a bit more of the portal vein, sphenic vein, and also the SMV going downwards. And you can trace this to the confluence. So another image showing you where the confluence is here. Common bile duct, portal vein, sphenic vein, SMV. So this is the colored appearance. Then I would usually trace the bile duct by doing a slow clockwise rotation. So clockwise rotating, so we will actually can trace the common bile duct from the hilar area towards the papilla. And also occasionally we would see the PD coming down from a bit lower and joining the common bile duct. After imaging the station 2, then I would reduce the scope like a ERCP maneuver. Show that I'm in the short scope position, and then the scope dropping down to D23 area. So if the scope is in the D23 area right here, the probe is imaging this side, then they will see the SMA, SMV. If we turn clockwise a bit more, then we will see the IVC as well as the aorta. So these are our landmarks in the third station. So this is a short scope position. So after the scope is inserted into the D23 area, we reduce the scope. This would be a short scope position. It will be, the probe will be facing this side. So if we use the big knob to tip up a little bit, then we'll be able to approximate the probe more towards the head of the pancreas. Then we try to find the landmarks of SMA and SMV. As we see the landmarks, then the scope position will be slowly withdrawing the probe. We would see the pancreas, and then eventually we were able to do this maneuver, which is kissing the papilla. So the probe is touching the papilla, and then we slowly withdraw the probe to image the common bile duct as well as the PD. So again, another image showing you what we are doing here. So the probe is here. We image towards this side. We use the big knob to tip up a bit more. So the probe will be facing this side, and then slowly we will image the entire head of pancreas. So just now we mentioned the vessels that we need to trace. Then on EUS image, the SMV, SMA would look like this. And once we see the SMA and SMV, then we would know the pancreas should be in front. We can talk around slightly to try to image the entire head and so as the uncindered process. But once we see these two vascular landmarks, we know we will see the pancreas. So this is just to tell you, the SMV should be closer to the probe, and the SMA should be further away from the probe. All right. So as we pull back the scope, we will see the uncindered process slowly coming into view. And then if we pull a bit more, we rotate clockwise and clockwise slightly. We would see the PD being more a horizontal structure. And if we counterclockwise turn a bit more, we will see the common bile duct. So counterclockwise common bile duct, clockwise PD. Okay, again, it's better to have video. So right here, my probe is in the bulb. Also in the bulb, we can actually see a lot of the right lobe of the liver, which is right there. This is the gallbladder. So this side is the gallbladder, clockwise gallbladder, counterclockwise, we see the portal vein and then the bile ducts. So pancreas, portal vein, splenic vein, and this is probably the bile ducts right there. So no flow, meaning it's a bile duct. Then we would trace the bile duct slowly towards the head. The PD is coming here, is around here. And then we trace to the papilla. Now the scope has changed position. So right, you need to reduce the scope first, and then we would try to identify the SMV, which is closer to the probe, SMA. So the pancreas uncindered process is closer to the probe. And we will see the PD, this is uncindered process. PD should be coming in view very soon. Okay. This is the main PD. And then rotating anti-clockwise, this is CBD right there. All right. So this is a summary of what to do for linear examination in the abdominal cavity. So I think practice makes perfect. So really, you need to get your hands dirty to learn it. Okay, so should I go on with my next lecture?
Yeah, please, Anthony.
Okay, thank you. All right. So once you master the technique of a linear EUS, of course, we all want to put a needle into the lesion. So FNA is a bread and butter for a sonographer. Recently, there has been many developments. I don't think any other specialty talks so much about FNA and all the minute details. I don't think if you talk to a pulmonologist, I don't think they have all these different needles for EBUS and also all these different techniques. So I think for us, we have really developed a lot of knowledge in this area. So of course, our dream in USFNA is to have 100% yield and accuracy, and hopefully get the diagnosis with just one single pass. There are several guidelines around. Here, I would like to highlight the European guidelines. The AEG is also writing up a guideline, and I think Dr. Chang Chong and others are working on it. But before that, I would just like to share this guideline from the ESGE. So there are several statements. First statement, solid mass or lymph node. We can use either a 22 or 25 gauge needle, FNA or FNB, depending on whether you need to know the histology or have some special staining. If you just want a diagnosis, I think FNA is still enough. For example, in patients with suspected recurrent lymph nodes, then FNA is also acceptable. But nowadays, our oncologists are wanting more and more tissue for diagnosis, not only diagnosis, but as well as genetic assessment. So core tissue specimen is often asked for, and we can use either a 19 gauge needle or FNB needles. So I usually would use a 19 gauge FNA or a 22 gauge FNB needle. For the ESG guideline, they suggest a 10 ml syringe suction. For me, I actually don't use syringe suction, so because I think it actually sucks out more blood. And actually, the evidence surrounding this statement is actually quite controversial. So I think this is for you to decide. For me, I don't use any suction. Stilet for both needles, plus or minus. For FNB needles, they would suggest placing a stilet. For me, I think with the stilet, mainly for the pro-core needles, you really need to have the stilet inside because with the side hole, if you don't have the stilet inside, the needle would actually break. This has happened to one of my patients, and with a broken tip needle inside the head of pancreas. In terms of technique, they suggest fanning. This will increase the yield. If you have rows, of course, on-site cytopathologist is preferred. But I think in most Asian countries and probably Sri Lanka, you don't have rows. So an alternative technique, which is known as MOS, is currently advised. And we have published a recent randomized trial confirming the usefulness of MOS. I would detail in a later slide. For pancreatic lesions without a solid component, I think I would do this as well, to empty this cyst with either a 22 gauge or 19 gauge needle. I prefer a 19 gauge because to suck any fluid out of a 22 gauge takes a long time. It's very slow flow. And in a cyst with mucus, then it takes even longer. For pancreatic lesions with a solid component, we would advise sampling the solid component. Antibiotic prophylaxis is generally not required. In the past, we suggest antibiotics for cystic lesions, but nowadays, with the recent randomized trial, again, it seems like antibiotics is not even required for cystic lesions. In terms of evaluation of tissue, Nowadays, more and more people are performing histological preparations. We also do this, so we would just push out all the tissue into a formalin-based container and send the whole tissue to a cell block examination. So, before all that, of course, I need to talk about how to perform FNA. This is a very technical procedure. But before you do so, you need to think, what needle are you going to choose? What size? FNA, FNB, side port, no side port. After we chose the needle, then we would need to insert the needle and adjust the position of the sheath. Before puncturing, we will turn on the Doppler to check for intervening blood vessels, measure the distance from the needle, puncture the target, have 10 to 20 passes for each puncture. Use a fanning technique during your pass. For me, no suction or stilet. After puncturing, I will push out the material. I will do a Mohs examination and check for adequacy of the specimen. So this procedure is performed by Professor Hara. So you can see there's a big pancreatic mass. Once you see the mass, we will insert the needle. So after you insert the needle, you need to adjust the position. Of the sheath. And then we turn on the Doppler to see if there's any intervening blood vessels. Okay, then we can insert the needle. I usually do this as a quick jab. Needle goes in. And then we set the stopper at this level. If you want to use suction, you turn suction in. Then you pull back the needle slowly, push in quick, pull back slowly, push in quick, pull back slowly, push in quick. So to and back more than 10 times inside the lesion. Pull back slowly, quick in, slowly out, quick in, slow out, quick in. Also, we would suggest to use a fanning technique. So we need to fan through the lesion and then withdraw the needle. Okay. So when you puncture, you also need to have some idea of where you are going to puncture. In terms of anatomic locations, it can be esophageal, gastric, or duodenal. And the difficulty would be most difficult for duodenal area because the scope is in a long scope position. Sometimes the needle in the duodenum won't come out. So you need to pull back your scope back into the stomach, push in the needle, and then afterwards reinsert the scope in the duodenum to puncture it. So this is why it's difficult. Stomach, inline position, duodenum, long position, sometimes very bent, and problems with needle movements. Okay, so going back to the various details of the technique with or without suction. So this paper published in CGH by Cheyenne showed that there's no difference for with or without suction. With suction, just increases the amount of blood in the specimen. So for me, I do not prefer suction. Stilet, should we use it for stilet? So in this very recent randomized trial using for histology, stilet with stilet or without stilet, 220 specimens, actually no difference in cellularity, contamination, bloodiness, and also diagnostic ability and accuracy. So for me, I would usually remove the stilet and do it after the first pass. In the past, we would keep the stilet because once we puncture, we want to push out the gastric wall material from the tip of the needle. But I think if you have enough tissue within the needle, probably this movement of pushing out this the stilet is not needed. In terms of suction techniques, recently there's been a lot of talk about the slow pull technique. So what is a slow pull technique? Slow pull technique is to keep the stilet in the needle, but as you puncture the lesion, you slowly pull the stilet out. So by this manner, you generate a very low suction force in an attempt to reduce the ability to the effect of sucking too much blood out of the tissue. Results from trials are very controversial. Actually, 2 trials showing no difference and only 1 trial by Nakai showing some improvement in the accuracy, sensitivity, as well as this, sensitivity. For me, I'm not a believer in slow pull technique because if you look at the pressure of slow pull, it's almost negligible. So the pressure generated by the slow pulling of the stilet is so small that I don't think it would actually have any actual effect on sucking out tissue. Only if you attach a syringe up to 20 to 50 mils, then you will be generating a big, really high suctioning force, which may potentially suck out extra tissue. So in terms of the site of the lesion, conventional teaching is that we always try to puncture the periphery of the lesion because in the center, if there is necrosis, it should be the center necrosis, and all the viable tissue should be in the periphery. And improvement of this technique will be the fanning technique. We will fan out the needle through different parts of the lesion so as to increase the yield. And again, from Shyam's group, showing a improved accuracy as well as first pass diagnosis with the first part fanning technique. So right here, this is a lesion, a large cyst in the stomach. It's around 3 centimeters in size. It's very heterogeneous. You can see areas of necrosis within the cyst, making me suspect this to be a high-risk cyst. Right here, I'm doing a contrast EUS. So why contrast EUS? I want to see a bit more on the vascularity. So right here, you can see the vessels are very irregular within the cyst. So I'm a bit concerned about it being a high-risk cyst. This is relevant nowadays, more so because we're doing more and more endoscopic resection. And in general, if I see a high-risk cyst, I would prefer more of a surgical removal rather than endoscopic. Here, I'm doing the FNA at the same time. So this is another technique that you can use. It's a contrast-guided FNA. So right here, the contrast would show areas of necrosis versus viable tissue. And I'm also trying to use a fanning technique to change the angulation of the needle from puncturing here to puncturing more middle and also towards another direction. Okay. So Rose, just now we mentioned that if we have on-site cytopathologists, it improves the diagnostic sensitivity. This technique is mostly practiced in US and maybe parts of Europe. But in Asia, I think most of our pathologists are too busy and may not be available for on-site cytopathologists. But if you do have a ROSE, then it has a very good sensitivity as well as specificity. But in this study, showing using an online questionnaire to ask about the practice patterns in the world, actually, ROSE is only available in 65% of the endosonographer. Reasons for omitting ROSE include limited pathology staff, disbelief in addictive value, high cost, and also additional procedural time. So if you include ROSE, you need to wait for the results to come back. Sometimes it can add another 15 or even 30 minutes to your procedural time. So in order to overcome some of these difficult problems, Siam has a course that trains endosonographer in Orlando to learn how to read slides for ROSE so as to reduce costs. And they did a study, 3 endosonographers, 1 cytopathologist. So in terms of the reading the accuracy of the adequacy of specimen, the endosonographer in terms of sensitivity and specificity is around 50 sensitivity. Cytopathologist, maybe around 60%. Specificity, 70 to 80%. Cytopathologist, 90%. So although a bit inferior, maybe still close. In terms of accuracy, the accuracy of determining suspicious lesion, I think here the endosonographer is a bit performs much more inferior as compared to the cytopathologist. But in terms of specificity, meaning very obvious tumor cells, then I think they are able to have a percentage close to a cytopathologist. For us, I think reading slides is difficult and a bit more tedious, so we would actually propose MOSE. So what is MOSE? So as we push out all the tissue into, we will also push out all the tissue into the slide first and observe for areas of white tissue. If there's a white tissue, then we would cut out all these white tissue and have this sent into one box, one bottle. We also measure the length of the tissue. Usually if it's all the white tissue is more than 4 millimeters, then we think it would be enough to decide on the adequacy of the tissue. So you can see here, these are the material being pushed out from a needle. The whitish material right here, here are all the tissue, viable tissue that we want. And you can see from the slide estimating already it's more than 4 millimeters. So the circled yellow area is the area that we are interested in. We will send all the white tissue into formalin, the red core also in formalin, and then the bloody fluid as well as the needle flush. So after pushing out the material, we will flush the needle with additional saline. This would go into the cytology bottle. So in terms of MOSE, if the length is more than 4 millimeters, sensitivity can be up to 92%. And if you combine both cytology and MOSE, you can reach to an over sensitivity of 95.5%. And in this randomized trial that we've published, MOSE can reduce the number of passes. The average number of passes is 2. And for bloody contamination, it's much lower in the MOSE arm. And in terms of the adequacy from the tissue, is comparable to both the conventional approach. So just now I mentioned a bit about histology needles. In the past, we have the option of true cut needle, but I think this is no longer used. And now you can either use a 19 gauge needle or a fine needle biopsy needle. If you use a 19 gauge needle, you need to be aware because it's very stiff. If you have the option of a Nitinol made 19 gauge needle, then it will be less stiff. But the fine needle biopsy needle is a bit more expensive. So you need to decide what is best in your practice. These are the new types of the core biopsy needle, including the Procore, Shakor, and also the acquired needle. This is another type of needle. It's not a core biopsy needle, but it allows a biopsy forceps to be inserted through a 19 gauge needle, so giving you a histological sample. Pros allows core biopsy, higher accuracy, less number of passes, no need for rows. Cons, expensive. 19 gauge needle will give you a very nice core, like here. Here is a 22 gauge FMB needle. So again, a lot of white tissue, properly core tissue. So this is the slight difference in the type of specimen that we get. So 19 gauge needle for core biopsy, you can get histology samples in over 90% of the patients. So a good alternative. So in terms of the different types of core biopsy needles, this is a fork type. Fork type core biopsy needle, which is the shark core. Accuracy a bit higher in the FMB needle. Sensitivity higher. Sample time shorter. Pathology review time shorter. Tissue amount of tissue greater as abundant, significantly higher. So benefit of FMB needle is histology and also accuracy. This is a fork type needle versus a side fenestrated needle for needle biopsy. Procore versus Shakor. So in the Shakor arm, they have shown the histology yield 90% versus 60%. Blood contamination 6.2% versus 92%. And tissue integrity more than 10 cores, 7% versus 0. Insufficient material 7.3% is Procore arm. So favoring the fine needle biopsy needle, so Shakor needles. In terms of 22 gauge acquire versus 20 gauge Procore, interestingly, again, favoring acquire. Adequacy, 100% versus 82%. Accuracy, 87% versus 67%. So favoring acquire arm. So even within the different types of FMB needles, different brands actually have some differences in the outcomes. This is the acquire needle versus the Shakor needle. In this study, seems like there's not much difference between the two types of needle. So with so many benefits about FMB needle, so the idea came as to whether FMB with most would be comparable to the gold standard of FNA plus ROSE. So the needle of FMB needle is maybe more expensive, but if we can use it with most and not ROSE, then we would save costs from the lack of a pathology input on site. So this is a trial that we are doing now. So if anyone's interested, let us know that you want to participate. So finally, another new kit on the block is a through the needle biopsy forceps. So this is the 19 gauge needle. The forceps goes through the needle and we can open and close the biopsy forceps. So it's a very small biopsy forceps. So as a result, although it's still a biopsy forceps, the tissue that is obtained from such a small biopsy needle is very small. So I think most useful would be in pancreatic cystic lesions. If there's a nodule somewhere, then we can insert the needle and biopsy using the forceps. So in the past, we would use a needle to puncture the solid component, but now we can use the biopsy forceps. Open and then just biopsy the wall of the cyst or a solid component. So usually we need to biopsy 2, 3, 4 times because the bite is actually really, really small. Here we are biopsying a small nodule. And then remember, after biopsy, we should try to aspirate everything out. So from this study, 49 passes were performed. Histological core, 70%. Tissue acquisition, 67% per pass. And overall accuracy, 88% per pass and 94% per session. Another study showing that for pancreatic cystic lesions, in this systematic review, the concordance rate with surgical pathology was significantly higher with the through the needle biopsy forceps. So in conclusion, I think for USFNA, again, you need to get your hands dirty to be expert in this procedure. I think it's an essential procedure that you need to master. In terms of the devices, there's a trend to move from FNA to FNB. It appears that the Frankstein and Fock type needle may be associated with better outcome. And for cystic lesions, there is also another option of using the through the needle biopsy forceps. So thank you for your attention. Any questions?
Thank you, Professor Teoh. So if any attendees would like to ask the question, please type your question in Q&A. So after you type in, we can see it and we're able to answer. So maybe our trainee needs some time to digest the information. So may I invite Professor Andrew Kwek to have his presentation. Professor Kwek, please.
Yes, thanks, Jason. Good morning, or is it good afternoon in Sri Lanka, right? Greetings from Singapore. Thank you, Nilesh, for your kind intro. And thank you, Anthony, also for your very nice talks. What I'm talking about today will be on how to prepare US FNA specimen for cytology and histology. Let me try and share my slides. Yeah? Okay, so these are our objectives today. I'll review the basic techniques for aspirate handling, and then we'll review the fixation and staining methods, as well as cell block preparation. And this is in a context where, as the practicing endoscopists, a lot of times we may not have the rapid on-site cytopathologists or cytotech. Over at my center, we normally would do the FNA on our own. We'll prepare the slides and we send them to the pathology lab. In cases where there was previously a non-diagnostic result, we may elect to have the cytopathologist or technician available to comment on the adequacy of the specimen. So specimen handling is quite important because if we don't prepare the slides properly, our pathologists may not be able to interpret the specimen and give us a good diagnosis. And in terms of diagnosing a sample, we need to understand the concept of adequacy and cellularity. So adequacy is, for example, if we were to do a FNA of a specific organ, for example, the pancreas, the specimen itself should contain the lesional organ cells. So while it's not standardized, there are some recommendations, for example, for pancreatic FNAs, that there should be a fixed number of cluster of pancreatic acinar cells before we say that the specimen is adequate. In terms of cellularity, that can be broken down to the number of lesional cells that are seen. And this can be affected by how contaminated your specimen is. There are various factors that can affect adequacy as well as cellularity. For example, if we were to leave the slides to dry before we actually then prepare it to be fixated for wet smear, there might be false impressions in terms of the cellular structure. And that leads to a lot of artifacts, which makes it difficult to comment on the diagnosis. For organs that are having acute or even chronic inflammation, the level of inflammation may also obscure certain diagnostic details. And of course, blood contamination. There are certain diagnostic pitfalls that we should be aware of, and these are poor collection techniques, poor fixation, the presence of inflammation, cellular changes that are related to radiation or chemotherapy, as well as when there may be cellular changes related to bleeding, infarction, or necrosis. Anthony has brought you through the types of needles available. Traditionally, we have FNA needles, and with the newer generations, FNB needles, the amount of specimen that we get has improved. The popular FNB needles include those from Kwek, Olympus, Boston Scientific, as well as the Shockhorn needle. And there have been recent studies that have that Anthony has elaborated. And there are certain techniques that will increase the cellularity as well as the diagnostic accuracy. So whether to use starlet, whether to use suction, different needles may give different performance characteristics. But eventually, when you get a needle aspirate, this may be the material that you see on your slide once you push out all the materials. And if you look at the types of material available, the best is when you can see this whitish core, because this is actual tissue. And we want to save that to be done as a tissue processing or as a cell block. Now, the blood coagulums here, this can also contain small amounts of tissue and should not be discarded. And that's why we also send it in formalin. The liquid material in this diagrammatic representation, we can actually smear it, and that can be sent as a cytology specimen. But the rest, the tissue core, the blood coagulum, we send it in formalin. Cytology smears can be fixated in alcohol, which I will elaborate more in a while. But as a practical guide, for many of us who may not have on-site cytopathologists, I'm going to bring you all through certain things that we commonly do. So first thing is to have equipment ready. Next is the smearing technique, as well as some recommended number of slides, the type of fixation that we can do, and as well as the gross visual assessment. So this is the equipment that we normally will prepare. We have glass slides to do the smears. Okay, these are for cytology. You can have a toothpick, or you can actually use the bevel of your needle to pick up the small tissue fragments that can then be put in a formalin bottle. The smear slides itself will go into a container that is usually filled with 95% alcohol. Now this filter paper, these are strips of filter paper. I use these when we picked up certain tissue fragments. We'll place it on the tissue paper and then we put it into the formalin bottle. In terms of smearing technique, now the aim is actually to create a monolayer of cells so that it can be seen through the microscopic evaluation properly. Don't forget, of course, to label the slides with the patient's name and IC. And using a second slide after putting a drop, we gently smear it firmly across. Yeah. Now try to avoid too much force, as it may actually cause crushing and shearing of the cells. For each pass that we do for the FNAs, I would suggest to have a minimum of 2 slides or more, because if any of the specimen is lost or contaminated, that pass would then be non-diagnostic. So try to have at least 2 slides or more. And if you have 3 or more slides that appear to have sufficient cells or specimens, then you can put the rest of the materials that you collect into a formalin bottle and send it off for cell block. Now, what is fixation? Fixation is when we try to stop the degradation process of the biological material that we've aspirated. And there are 2 types of fixation in general. We can fix the material, what we call a wet fixation. And this basically means that before the material dries up, it is fixated. And this is done by immersing the slides before they dry up into 95% ethanol, or you can use a spray fixative that is alcohol-based. Now, wet fix smears are usually stained with the Fernandopulle stain, and Fernandopulle stain is it's quite a popular stain that's used by many pathologies. It has got good nuclear staining, it's got cytoplasmic counter staining, and it's popular among pathologists because the cells, when looked under the microscope, they appear semi-transparent. So you can see a bit of a 3-dimensional features. Even overlapping cells can be assessed. It's got clear nuclear features as well as chromatin pattern. So this is my favorite kind of fixation, wet fixation, and subsequently pap stain by the pathologist. Some other practitioners, they may send half their slides as wet fixation and the other half as dry fixation. So dry fixation is when we leave the slides to dry by waving the slides or using a hairdryer, and then they are stained using the Romanowski type stains like Kwek, a very popular type of Romanowski type stain. And these are done a lot by the cytotax or cytopathologists on site because it's a rapid stain. It has acidophilic dye for the cytoplasm and basophilic dye for the nuclear stains. It does highlight cytoplasmic features as well as extracellular substances better. But it has to be important to note that for dry fixation, they have to be done properly also. It has to be completely dried before going through the next process. So this is an example of a Kwek stain. It's got short staining time. It's usually done by the cytotax for rapid on-site evaluation for adequacy. You can see things like mucin, fat droplets, neurosecretory granules. You can look for microorganisms, as well as looking for Helicobacter or even spermatozoas. So the choice between whether you like wet or dry fixation is something that you will need to assess for yourself in your discussion with your cytopathologist also, and then have a standardized system for your own center. Lastly, when we look at the specimen that you have, you can actually gauge cellularity just by gross assessment. So for example, if what you've aspirated from the material looks like this, and the actual organ that we did an FNA on is a lymph node, you know that this is probably a necrotic lymph node with a lot of necroinflammatory cells. If it's a pancreatic cyst with very thin fluid that you've smeared, looking like this, you will know that there's not going to be much cytologic details. If you do get a specimen like this, which is ideal, you see core tissue, you see a little bit of blood with fluid. When you smear this, pick out the tissue fragments, you're bound to get a diagnostic, positive diagnostic yield. Now, if you were to remove those tissue fragments, or if you were to use some of the aspirated material and put it into a buffered formalin, 10%, you can send this off and the pathologist can do a cell block for you. So cell block basically uses this material and the fluid, they centrifuge it or they cytospin it, and they use the material that is collected and embed it within paraffin and treat it like a tissue histology. Now this is useful because you can actually, besides just looking at it like histology, you can do immunocytochemistry. And for certain pathology, like a neuroendocrine tumor, is quite useful. It can stain for certain neuroendocrine markers like chromogranin, synaptophysin, and that will be useful to get a diagnostic, positive diagnostic yield. Lastly, if you have a core tissue, it may appear like this, and this was using a 20 gauge Procore needle with suction. So you do see quite a bit of blood coagulum. This was material from lymph node. There were whitish tissue, there's blood coagulum. I basically just collect all of this onto a filter paper, put it into formalin, and then we set it off where they can then assess it as tissue histology. So in summary, what I've talked about is about understanding that we need to get the right organ, trying to get the right number of cells, having adequate lesional cells, having good cellularity in our specimens. We need to have good smearing techniques so that we have a smooth monolayer of cells. We don't want to have overlapping material that would be non-diagnostic on the slide. The types of smears that we can send, the cytology slides, you can fix it either as a wet fixation or dry fixation. If you have tissue cores or tissue fragments, you can set it off as to do a cell block or to look at it as histology. And then how the pathologist will then stain it depending on how we fix it also. So some quick tips: aim for a smooth smearing spread. If you see visible tissue fragments, pick it off with your needle or with a toothpick, place it on filter paper, and then put it into a formalin bottle. If there are no tissue fragments, you can do further aspirations and send off whatever you aspirated as a cell block. So you have to put the aspirates into buffered formalin. For wet fixation, place slides into alcohol before they dry, because it may cause artifacts if you allow it to dry on the table before you put it into your alcohol containers. And lastly, but most importantly, I feel, have a conversation with your institution's cytopathologists, because they can actually give you very valuable feedback on best practices and how to get the best out of your FNA practice. So, I'll end here because the next slide is actually going to be on the answers for the pretest. Okay. Okay, so back to you, Jason.
Thank you, Professor Kwek. So next, Dr. Nilesh, do you have? So shall we move on to the Q&A section?
Yep, I think we can do that, Jason.
Yeah. So unfortunately, I cannot see any questions from the Q&A. So maybe can I invite Dr. Nilesh? Do you have any questions to our faculties?
Yes, I think Anthony and Andrew have gone through all the steps of diagnostic EUS in the stomach and duodenum, so probably it was very clear for all the attendees. Just one question probably to Anthony. How do you position the patients for endoscopic ultrasound? Do you put them like a ERC semi-prone version or lateral position? I know chain the how you do an endoscopic ultrasound also? How do you recommend it?
Yeah, I think for our elective EUSs, most of the time will be a left lateral position. But in some patients where we're planning for intervention or when we're planning for plus or minus ERCP, we will place this patient in a prone position so as to avoid the need to change positions during the procedure. So can I just ask everyone's practice technique? So Nilesh, what is your usual practice for biopsy? What needle do you use? Do you use suction? Do you use stiletto? What is your usual practice?
So yeah, in Sri Lanka, so yeah, I use the Silat and a slow pull technique. Unfortunately, in Sri Lanka, we do have to repeatedly use our needles on several patients. So we actually have to use EO gas, and then so we use a needle maybe up to about 5 times sometimes. Try to reduce the number, but so that's a problem. So actually, when you said that when you talked about not using antibiotics, sometimes I guess when you repeatedly use needles, probably even antibiotics might be needed for the repeat patients. So that's a problem that we have in Sri Lanka due to the cost. So,
okay. And what is your favorite needle?
We have the Boston Scientific needles and the Olympus needles.
So you're using the Easy Shot 3 and the
Easy Shot 2 is
Easy Shot
what's available, the cheaper one. Easy Shot 3 is also available, but it's a bit more expensive. For the moment, we use Easy Shot 2 for the patients who can afford it. Yeah, go for Easy Shot 3. Because in Sri Lanka, all the needles are given free by the government. So we have to look at the cost factor also. All these procedures are free for the patients. So the cost factor is a big component for us.
Okay. Andrew, what's your practice?
We commonly use for solid masses, we use the Procore needle. So the 20 gauge ones, and if it's in a difficult position, for example, in the deep duodenum, pancreatic head, I can even use the 25 gauge Procore needle. And I use stylet. We remove the stylet and then we put a 10 mils suction syringe. If it's a bloody specimen, then the second pass will be without suction, and it'll be a slow the capillary pool. Yeah.
So for us, I think if we want to have a histology assessment from us, it will be Boston acquired needle, 22 gauge. I usually use no suction, no stilet. And then if I don't get enough tissue, then I will apply suction. So in reverse. So just for the participants, why I ask these questions, you can see all of us have very different practice in terms of FNA. So actually, depending on what you like and what you have in your unit, there's actually no perfect answer. I mean, no right way. So everyone has their own different techniques and reasons why they choose that technique.
The participants have any questions, I think you all should shoot them out now, because you will not get a chance to speak to the world's experts in endoscopic ultrasound at a different time. So if you have any doubts in endoscopic ultrasound, please ask whatever, even if it's a simple question, please go ahead.
So in the meantime, while we are waiting for the questions, maybe I can launch the post-test first and let the participants to have a look on the question. While finishing the post-test, they can think of any questions they want to ask.
Okay, Nilesh, I'm sorry, but can I be excluded earlier because I need to run for another procedure. So
Anthony, thank you very much for coming and joining us in this webinar and teaching all the basics of endoscopic ultrasound, linear endoscopic ultrasound. So yeah, hopefully we'll meet sometime.
okay. Thank you very much. Enjoy.
Okay, see you. Bye.
So now everyone, you will see the post-test now has launched. So please take your time. The questions are the same as the pre-test. So we would like to see if you get the answer wrong in pre-test, I hope you can get the correct answer in the post-test after the lectures. Please take your time. So I'll give you around 3.5 minutes to complete it. So as Professor Teoh has left our webinar, so for the questions which set by Prof. Teoh, may I invite Professor Andrew Kwek to explain as well later on. Thank you very much. Okay, it's about time. So I'm going to reveal the results. Please allow me to share my screen. Okay, can everyone see my screen now? Okay. So, first questions. The first question is come from Professor Teoh. So the left side is the pre-test result and the right side is the post-test result. So the answer is E of the above. May I invite Professor Andrew Kwek to give a little bit explanation to it?
Yeah, it's quite self-explanatory. Yeah, all these needles, the 19 gauge needles are the, so here's talking about histology calls, right? So getting enough tissue. So the 19 gauge needles are large. You can get more material from it. And then for the pro core, acquire, and sharp core, these are modified needles. These are the newer generation needles that are needle biopsies. Yeah, so they will get more tissue also. So yeah, all of the above.
Yes, thank you. So we can see more people get correct answer after the lectures. So the second question is also set by Professor Teoh. The second question, which of the following techniques will increase diagnostic yield in US FNA? And the answer is fanning technique. So Professor Kwek, can you give a brief explanation on this one?
Yes, there are many studies that look at increasing diagnostic yields using various techniques. So some will say using stylet or without stylet. One technique, or stylet or without stylet, some studies may show higher yield in one method versus the other. So not very consistent. Similarly, whether to use suction or not. But fanning is something that is quite well recommended. So it is it's a best practice. When possible, try to use the fanning technique to increase your diagnostic yield. Yes.
Okay, thank you very much. So comes to the question set by Professor Kwek. So it's a 4 true or false questions.
Okay. Okay, so let's start with the first one, right? Wet fixation is performed using Kwek while the slides are still damp. So when we talk about fixation, so the answer is false. Because wet fixation just means that before the slides dry, that means while they are still damp, it needs to be fixed. But you don't fix it with Kwek. Kwek is a stain. So it's actually it's kind of like a trick question. Sorry for that. The fixation is actually using 95% alcohol. All right. Now the next one for core specimens, let's see. So yes, almost everyone got it right. Yes. So any tissue fragments or core specimens should be placed in formalin, and thus they can then be treated as for histological specimen or cell block. For the next question, dry fixation is performed with the slides immersed in normal saline after drying. So this also is a little bit tricky because I kind of confuse you guys by saying, okay, it's dry, but then you immerse it in saline. So dry fixation, what I do is once the slides dry, we send it to the pathology lab. They will then actually process it. The first thing they do is actually to fix it in alcohol also. So this is also a bit of a trick question. And then the last one, additional aspirated materials can be sent for cell block and then placing formalin through. I think almost everyone got that right.
Yes. So thank you, Professor Kwek, for his explanation. So the process comes to an end. So just a brief reminder that when we end our workshop today, it will automatically goes to an online survey. So if you have any questions, any problems during the webinar, or any question you want to ask, you can still put your question in your after workshop survey or questionnaire. Then when we see the question, we can get back to you by email. So that's all for my sharing. So I'll give back my time to Dr. Nilesh.
Right. I believe there are no further questions, so probably we can wind up the workshop. So a big thank you to Andrew and also Anthony for coming and doing a presentations on diagnostic basics of the diagnostic and EUS, and also how to prepare slides. I know these are difficult times for all of us, and AEG has come forward to, I think, try to do the best out of what is available. So hopefully we can, next year we'll have a proper workshop. Unfortunately, we couldn't have the live industry workshop this time. So for anybody who is interested, Sri Lanka is having the live endoscopy workshop on the 26th of November. And so we'll also be probably showcasing a lot of the US cases there. And if anybody's interested, I just put my email address on the chat box. So anybody who wants can email me, and it's free registration for anybody, and they can get see all the live endoscopy workshop. Thank you for Olympus, Jason, and Dixon for arranging doing all the background work, and also Fiona from AEG for helping to organize this workshop. Thank you to all of us.
Thank you very much.
Thank you.
So yeah, maybe it's time to end.
Yeah.
Thank you.